Okay, well, why don't we get started? So hi, everybody. Welcome to Grand Rounds. For those of you on Zoom, I think they're med students. For those of you who don't know me, I'm Justin Salerian. I'm one of the vascular neurologists here at Tulane. For all of you in the room, it's really nice to see people in person. I hope this lasts. Today we're going to be talking about neuroprotection and specifically therapeutic hypothermia as a possible model for neuroprotection. This is a topic that's been of great interest to me since I was a fellow here. It's actually been about 4 years since I gave this talk. I can't even believe that. And so without further ado, let's get started. I have no disclosures. This is a pretty complex topic. Neuroprotection is a very wide topic, and then therapeutic hypothermia by itself could be a full day's of lecture. But I think the best way to approach it is go through brief history, the physiology, spend a decent amount of time on the cardiac arrest studies, post-arrest studies, which tend to cause confusion because there's been some mixed data there. A little bit about hypoxic ischemic encephalopathy in infants, models in stroke, animal models in stroke, and then talk about our Tulane stroke study. So therapeutic hypothermia is not a new idea. In fact, it's been around for thousands of years. Even Hippocrates had written about using snow and ice packs to reduce hemorrhage in the wounded, causing vasoconstriction. Napoleon's chief surgeon had used ice packs as a form of anesthesia to render procedures less painful. He had also observed and written that he noticed that soldiers that were closer to the fire, who had been wounded, were dying quicker. Sir William Osler, Dr. Osler of Johns Hopkins, noticed that if you were to cool typhoid patients in the 1800s, mortality would be reduced from about 25% or so down to 7%. Dr. Temple Fay, he invented the modern cooling blanket. You might even recognize. This looked very similar to one of our Blanketrol blankets that we used today. Basically, water is flowing through a capillary system that's cooling one of these metastatic breast cancer patients. And he noticed that when he would cool these patients to 32 degrees for 24 hours, he could get a pretty robust pain reduction. Dr. Peter Safar in the 1920s had a broad vision of hypothermia. Thought could be used for neuroprotection and surgeries to reduce exsanguination, fever prevention, and pain control. So it's not a new idea. And if we go to more modern times, and we just think about every winter, for those of you who are from the Northeast or anywhere pretty much other than the South, every year you'll hear a story of a child or an adult who's fallen into a frozen lake or a frozen river, and somehow miraculously they had this recovery, even though that they were down in the river maybe 20, 30 minutes, like in these cases. And in this one case here, it was 30 minutes of anoxia. Body temperature when the patient was found was 25 degrees. They had an hour and 40 minutes of CPR, yet a full neurologic recovery after the ICU stay. Another teen submerged 15 minutes, body temperature 31.1, downtime 1 hour. These are actually not that uncommon of stories. If you just do a quick internet search, you can see a lot of them. The question is there something to that or not? And if you look, I mean, being down for an hour or an hour and a half and surviving that with good neurologic function is a pretty miraculous thing, especially once we're going to talk about the cardiac arrest studies, where we know that once you're beyond 10 minutes of arrest time.
Video on everyone.
What's that?
Oh, sorry.
I hear Shannon.
I apologize, Dr. Salerian. It's Shannon.
Oh, it's okay. As long as everybody can hear. So what I was saying is being down for an hour and surviving that with good neurologic function is pretty much unheard of at normothermia. And we will see that in the cardiac arrest studies. In fact, when they first started doing human cardiac arrest studies in the 1950s, this is a case series that was done. This was just a small sample of patients, 19 patients with cardiac arrest, different origins, where they purposely cooled one group and didn't cool another group, showed a 50% survival rate when dropped to 33 degrees C, compared to a 14% survival rate in the normothermic group. So why is this? Why would hypothermia work for neuroprotection? Or how could it have these benefits? And it comes down to basic chemistry and biochemistry. And we should remind ourselves of the theory of Arrhenius's theory of thermodynamics, which says that a chemical reaction speed will double for every 10 degrees you increase temperature. And that really is starting at room temperatures around 21 degrees. But so for every 10 degrees you go up, you double. For every 10 degrees down, you cut in half. And so that means you can have a pretty powerful effect from a small intervention. There is an exponential increase in chemical reaction speed that is directly linked to temperature. So it might only take 1 or 2 degrees to have a pretty profound effect on metabolic rate. And this had been tested many times in the 1950s on animals. This is one such experiment of 4 dogs where they were actually, if you can see here, they would measure metabolic rate using O2 consumption as a proxy for that. And on the x-axis temperature, I don't know if you can see down here or if it's blocked. Looks a little blocked, but it's basically going from 35 to 27 degrees down here. And you can see a pretty nice relationship between the metabolic rate going down as temperature goes down. And in fact, it was 7% decrease in metabolic rate per 1 degree C. And over this small temperature drop, they were able to demonstrate a 50% drop in metabolic rate. Well, then the other question is, okay, well, you've dropped that far down. Can brain tissue actually function at such low temperatures, function properly, even though the temperature has dropped? Well, on the other side here, we have cerebral blood flow, which also went down to in the same degree, suggesting that autoregulation was actually intact all the way through the temperature regulation, suggesting that the brain tissue was functioning at least baseline normal. Other observations were, of course, reducing oxygen demand, preserving phosphate stores, reducing acidosis, all as a consequence of small reductions in core temperature. And then we can turn to nature, but you didn't think I'd be showing you a ground squirrel here today. So this is an Arctic ground squirrel. Actually, it's hibernating in this picture. This wonderful animal is able to drop its core body temperature to negative 2.9 degrees C. That is not a typo. Core temperature drops to negative 2.9 degrees C, which is below freezing, and its brain temperature just stays just above freezing for 10 to 21 days throughout winter months, and will rewarm itself up in that cycle. And during this time, when it is very cold, it will drop its heart rate to about 1 beat per minute. Again, suggesting that in nature, we know that biological organisms can actually survive even low temperatures and have adapted to do so. So if we apply what we know about Arrhenius's theory that all of this is that the temperature has an exponential effect on chemical reaction speed, well, how does that apply to neuroprotection? Well, we know the brain is extraordinarily hungry. It's the most metabolically active organ, requiring 20% of cardiac output. So if you so the second it doesn't get blood, oxygen, glucose, it starts to die and undergo inflammatory responses. And so once you have an injured brain, you get an inflammatory response with cytokine release, free radicals, and of course your caspases, which essentially message cells to say, hey, it's time to pack up and die, and set in motion apoptosis. So you could imagine a scenario where you might have injured brain. We talk about this every day on the stroke service, where some might be dead, but some might not be. Some might be penumbra. And that penumbra could be getting chemical signals saying, hey, it's time to die. We should go through an apoptotic process, potentially to save the rest. Well, maybe with hypothermia, all of this entire inflammatory cascade will be influenced by temperature. Perhaps we could reduce the amount of inflammatory cytokines that are released, including the caspases, that might lead to apoptosis in a cell that may not otherwise have been destined to die. There have been many animal models, demonstrating the beneficial effect of hypothermia on neuroprotection in rats. And this is one in pigs. And I'm going to show you this one because sometimes I think a picture or a video is worth 1,000 words. And this one, this study, in fact, is using the life recovery thermosuit, which we are currently using in our Cisco trial to rapidly cool stroke patients. So this was a study that was done in the University of Vienna, where they took 16 pigs and randomized them to either a cool group or a therapeutic hypothermia group or a normothermia group, after they gave them cardiac arrest. So they arrested them on purpose. They did 8 minutes of CPR. They defibrillated. Then they were randomized to either be cooled immediately or to be normothermic. And so this totally means, in effect, this means 18 minutes of downtime, either low or no flow time, as it's said in cardiology. So when the assessors came to the pigs, they were all blinded. They didn't know which pig that they were seeing. So this video is taken from a blinded assessor. So for those of you who are sensitive, I'm sorry. But this pig, as you can see, has got extensor posturing. You can see its legs like that, cannot stand, cannot balance itself. It is neurologically quite injured. This is a warm swine, although the assessor did not know that at the time. So then the assessor came to another cage, and this is what he saw. Pigs running around the room, doing pig things. Here pig, pig, pig. I can't catch him. Can't catch him because he's acting like a normal pig. This just so happened to be a cooled pig. So was this a fluke? This was a pig that was cooled immediately after cardiac arrest? Or is there a trend here? So in fact, it was not a fluke. All 8 pigs who were cooled, for some reason the format got changed here, but you get the point. All 8 pigs who were cooled immediately after cardiac arrest had normal neurologic function versus only 1 in the normothermic group. Okay, there are many animal models of this demonstrating this. This is how the human studies got approved. But I think seeing that video and actually seeing what the assessors see, it kind of brings it home for you. This is the life recovery thermosuit, which I'm going to talk about a little bit more later. So the first human trials, the first landmark human trial that started to change the perception and change practice was called the Bernard study. It was done in Australia in 2002, randomized prospective blinded rater trial using mild hypothermia versus normothermia in cardiac arrest patients. It should be noted that there is no one consensus about what we call mild, moderate, or deep. But it is generally accepted that mild hypothermia is between 32 and 34 or 32 and 35, depending on who you ask. Moderate is between 30 and 32, and deep is between 28 and 30. Anything below 28 is considered unsafe. and it's called Profound. 1 second. So this was 77 patients within 2 hours of ROS. Primary outcome was survival to hospital discharge with good neurologic function. And they used something called the CPC, which is very similar to a modified Rankin score. CPC is cerebral perfusion category. It's basically, instead of 0 to 6, it's 1 to 5, I believe. And 1 and 2 is considered good. 1 is almost no disability. And 2 is you have some disability, but you go to rehab, which is what we want in our stroke patients as well. And they had to have a VFib arrest. So these are shockable arrests. And be in persistent coma after return of spontaneous circulation. They couldn't have cardiogenic shock, a bunch of other things, which I'm not going to go into right now. Their cooling method, which is important, this was all surface cooling. They used ice packs from head to torso. And they actually were able to start cooling in the ambulance to get them down quickly. In order to avoid shivering, which we'll talk more about at the end, they were able to use muscle blockade, midazolam, buspirone. Just like any good neurocritical care, you had to keep the environment wholesome. So the end result here was that you had a profoundly favorable study here with 49% in the hypothermia group versus 25% in the normothermic group having a good neurologic outcome. And this was quickly replicated by the hypothermia after cardiac arrest study in 2002. It was a significantly bigger study of 237 patients. They also used only surface cooling, and that's important because how you cool can also change your adverse effect profile as well. For instance, and I will talk about this a little bit more, but intravenous cooling with IV saline has been shown to increase the risk of pneumonia, pulmonary edema, and cardiac arrhythmias. So this was all surface cooling, 32 to 34 degrees, so mild hypothermia for 24 hours. There was no difference in pneumonia or sepsis. There was some trend towards that, but no actual difference statistically. And I already said the outcome, 55 to 39%. Not quite as powerful in terms of an absolute difference as the previous trial, but still unequivocally favorable. That essentially became practice changing because you had 2 back-to-back randomized controlled blinded rater studies showing that it became standard of care to start cooling patients post-cardiac arrest out of hospital who still had persistent coma. Then came the 2012 studies, the shot heard around the bow, as I say, which was the target temperature management. All of this really is targeted temperature management. You're targeting mild hypothermia. In this case, in this study, what they were hypothesizing was that, well, maybe it's not the hypothermia itself. Maybe it's just better control of temperature and avoidance of fever. And perhaps maybe you don't need to go that deep. Maybe we could go just to 36 degrees and there might be no difference between 36 and 33. That was the hypothesis. This was a much larger trial, as you can see here, 939 patients, cardiac arrest, 20 minutes. They were much more liberal with their inclusion, allowing people to be down before ROSC up to 240 minutes. Again, intervention 33 versus 36 degrees for 24 hours, and they followed them up at 180 using the same outcome measures, CPC and MRS. Ultimately, this was a negative study. They found no difference between the cooled to the mild hypothermia group versus the 36 group. But they also said that, well, it wasn't harmful to cool at 33. And this caused a lot of centers, cardiac centers of excellence, to change their practice and liberalize their protocols to allow for either the provider to go to 33 or to 36, because this was such a large study. But why? What could explain TTM1? Was it a bad study? Was it poor methods or execution? I and others, my main criticism of this trial, even though it is very large randomized study, is the cooling speed. You know, you should think a lot about the way I think about this is like fruit. If you want to refrigerate fruit, you better do it before it rots. If you try and put a rotten fruit into the refrigerator and take it out, when you come back later, don't expect it to be fresh again. You have to be quick. You have to start this process very quickly in order for it to have a benefit. In animal studies, there's a clear indication that there's a therapeutic window somewhere between 4 and 6 hours. I will show you that when we get to those studies at the end. But my main criticism is that they started the clock at 130 minutes after ROSC, return of spontaneous circulation. So that's 2 hours after. And then they were slow at cooling. So once they actually started the clock, so they delayed 2 hours before actually cooling, and then it took them many more hours after that to actually get them down to target. So they were slow coolers and delayed coolers, and so they showed no difference. The other thing is that they actually used cold infusions in their hypothermia group, which we know increases pneumonia, pulmonary edema, and other such things. The third aspect, I don't know if it's if it's valid or not, but they had bystander CPR in the majority of their cases, which would essentially mean that you're overall going to have healthier patients if they get CPR very quickly. The other two studies did not have that. So that would be fine and dandy. But then just this year, which is actually what prompted me to say, hey, I need to do this grand rounds, there was a second TTM study by Nielsen et al. Almost twice as big as the first one, but this time looking at cooling to mild hypothermia to 33 or normothermia, but would still keep cooling devices on the normothermic patients to prevent fever. And in this one, they were looking at their primary outcome was death. Again, same result, no difference between the two groups. This is pretty depressing to see this, you know, as someone who has read as much as I can about the animal literature and the previous studies to see this, it's a bit jarring when you look at it. Again, no difference in death, no difference in functional outcome between the cool group and the normothermic group. And in fact, in their treatment group, in the hypothermia group, they actually found higher amounts of hemodynamic compromise, more arrhythmia. Okay, other adverse effects did not differ. Again, same main criticism. They were very slow, very slow. 136 minutes. Again, they didn't start the clock until 2 hours after ROSC. That's when we don't actually even know the exact time. All they say in their protocol is that we started counting after randomization, and the average time to randomization was 136 minutes. And then once they had that 136 minutes, it was another 200 minutes, which is significantly faster than they were the first time. But the total time is still 3 hours and 16 minutes post-ROSC. And if you compare that to Bernard, they were 2 hours post-ROSC. So this is 5 hours versus 2 hours. Okay, so I think that might be part of the story. I don't know, because the HACA study was somewhere right in between, and it was still positive. But I think if there are three factors that I want us to keep in mind, it's the speed of cooling, it's the depth of cooling, how low should we go, and the duration, how long should we cool. Even the authors admit in their discussion that timing may have been a contributing factor as to why they had a neutral result. Basically, and they were even saying that this is counter to what the animal models have shown us. When you're looking at speed and your time to cooling, in the Bernard study, which was the fastest of them of the post-cardiac arrest that I just went through, had 88% chance of favorable outcome in cooled patients versus normothermic controls. Whereas the HACA study, which was much significantly slower, only had a 41% chance. And then we lost that difference altogether in TTM 1 and 2, and it took them 5 and 10 hours respectively. Again, also pretty recent, they started testing the same hypothesis, not to beat this dead horse, in non-shockable rhythms, which typically have a worse outcome to begin with, meaning things like PEA or REST, which are usually your 5 H's and T's, but the biggest one being asphyxia or hypoxia. They cooled these patients, and they did find a favorable outcome, almost doubling the favorable outcome in the therapeutic hypothermia group, 10% versus 5.7. There was no difference in death. So this all came out in the last 2 years. So all of these mixed findings. So what do we do? In fact, this is one study that basically showed what happens when you reverse course, when you go from 33 target to 36. They found that it was much more difficult to maintain someone at 36 degrees, higher rates of fever, trend towards clinical worsening. Ultimately, this hospital ended up going back to a deeper cool. Cold infusion, like I mentioned, has trends for worsened mortality. There have been multiple studies showing that, so I'm going to just kind of blow through that. But the point of these is that timing seems to be a critical piece of this. When prior studies had been reviewed, 1 hour delay equaled a 31% chance of good outcome. In another one, 30-minute delay, 17% greater odds of poor versus good outcome. And then on the other side of things, when you had a rapid cooling study like this one, they were actually able to achieve favorable recovery in 81% of VT and VF patients. So where we are right now is that it is still an American Heart Association official guideline for post-cardiac arrest patients who are still in coma to be cooled to mild hypothermia of 32 to 34 for 12 to 24 hours. This is a class 1 recommendation based off of many trials, and class 2B recommendation for non-shockable rhythms. But I would say certainly stay tuned here, because now we have this other very large trial that just came out that has not yet been incorporated into their review. What about neonates? All is not lost here. So in neonates, it's not even a debate. The evidence is so powerful that therapeutic hypothermia works, that it is standard of care. So basically, Cochrane did a review. They took 14 trials and eliminated only the best quality ones, and only limited it to hypoxic ischemic encephalopathy of infants that were in the moderate to severe category as opposed to mild. They use both whole body cooling, like you can see here in this infant, or just head cooling, which is kind of adorable. And they had a median time to target in these studies of less than 120 minutes. So meaning that once these patients were getting cooled, they were at their target temperature within 120 minutes, and they had to initiate a cooling within 6 hours, okay? That's critical. And they based this time point based off of the animal studies in mice and pigs. What they ultimately found after reviewing all of these 7 different trials was that there was a 24% reduction in either death or neurodevelopmental disability, a number needed to treat of 7. In fact, multiple of the trials were stopped early because of loss of equipoise, meaning it just worked, and so it would have been unethical to continue. And you can see that here, that trend line here. This is all favoring hypothermia, and these are the trials. And it wasn't just death, of course, but major disability, cerebral palsy, developmental delay, blindness, deafness. These are all proxies for neurologic function, okay? And so it benefited all of those modalities at 18-month follow-up. So evidence is overwhelming for neonates, and it is considered standard of care for moderate to severe HIE. But neonates are actually significantly easier to cool because they have a very favorable mass to surface area ratio. So it's much easier to drop their temperature. And so as you can see, they were able to do it in less than 2 hours. And as we know, and I'm going to keep saying it until the cows come home, speed, depth, and duration are the critical factors to pay attention to when you're examining any of this research. And part of speed, the reason why, and I feel for, and having now cooled 9 patients, it is difficult to bring an adult human being's temperature down on purpose. We have thermoregulatory mechanisms that have been evolved over millions of years to keep us normothermic. And one of the key ways we do that is through shivering. And there's something called the shivering zone, which I want everybody to be familiar with, which actually peaks at a temperature starting about 35.5 degrees through 33.5. Once you get below that, it typically starts to fade away. But important thing about shivering is that it's extraordinarily stressful to the body. In fact, it increases metabolic rate and oxygen consumption by 40 to 100% when it's going on. And of course, we can treat it with drugs like meperidine or anesthetics or paralytic agents. You can do skin counterwarming, but there's one nice natural mechanism that can also take shivering away, and that's called the Hunter's reaction or Lewis reaction, which is just skin cooling. So if you've ever seen someone in the polar bear club jump in to an Arctic water that's like 2 or 3 degrees C and they stay there 5-10 minutes, well, they come out and they look beet red, kind of like this hand or like this young lady here. And what's actually happening is that once the skin temperature drops below 10 degrees C, it can no longer vasoconstrict, which it's doing in order to shunt blood to the core and maintain body temperature. And it also can no longer shiver, at least to the same intensity that it can above that. So you could potentially knock out shivering just by dropping temperature, which is kind of counterintuitive. Another way that we're protected and we are kept at euthermia or normothermia is through brown fat metabolism, which babies have a lot of, but basically uncoupled beta oxidation, where the only thing that it's actually doing is just burning fuel to create heat. This is not in any way impacted by paralytics. It can increase metabolic rate by about 80%. And again, both of these things, shivering and brown fat metabolism, if you're going through this period, you're actually increasing stress and metabolic demands unwittingly. And again, if you drop below 33 degrees, you can actually knock out the majority of this metabolism because it is temperature dependent as well. So what does this mean? So there is this shivering zone, which we just talked about. And if you look at the Bernard trial, which was of the ones that we just looked at, was the fastest cooling of the cardiac arrest trials. You can see they stayed in the shivering zone for maybe 1-2 hours or so here, dropping right below that. And then they stayed under it. Versus the TTM trial, which stayed in the shivering zone for about 8 hours, which you can imagine is quite metabolically stressful. You're actually increasing metabolic activity because of the shivering. You have to give more drugs and because of brown fat metabolism, et cetera. So maybe that could be part of the reason. On the flip side of things, when you look at a study like the Kaneko study in 2015, which took 467 patients and were able to actually successfully rapidly cool them, and in fact, got them to target temperature in 180 minutes, they had a 7 times greater chance of a good outcome if resuscitated in less than 30 minutes and cooled to 33.5. So there does seem to be some speed component here. The faster you get there, the better patients tend to do. When you compare the slower cooling TTM trial here, there's no difference between control and 36 versus a faster study like Kaneko. There was a significant difference. And when you look at kind of bird's eye view of all of this, when this was published, all of the studies that had been published at that point, the picture starts to become a little bit more clear that cooling rate is a factor, and the total time it took to get to target temperature. So if you look at cooling rate, these are the slower studies, meaning about 0.5 to 1 degree an hour you're dropping, versus the faster cooling studies had a significantly higher chance of having a favorable outcome in post-cardiac arrest. And again, if you look over here to the hours from ROSC, meaning they went down, you got them back, how long it took you to get them to target temperature after that? Well, when you look at the ones that were fast, they were 70, 80% chance of favorable recovery versus the slower trials down here, where you can very clearly see had lower chance of favorable recovery. And again, note there seems to be this split here around that 4-hour mark, something to do with this 4 or 6 hour mark. I don't know. It seems to be about the therapeutic window. So speed matters, depth matters, duration matters. We haven't really talked about duration as much yet. So what about stroke, which is what we're all here for in neuroprotection? So we know that fever is bad, right? We talk about it in the neuro ICU and stroke service probably every day. But what you might not know is that this has been looked at from multiple different angles. One study showed that for every 1 degree Celsius you go up in temperature, you have a 2.5 times increased likelihood for poor neurologic outcome. Fever is associated with high mortality, poor neuro outcomes, longer ICU stay, longer hospital stay. Okay, it's pretty clear, even when you control it for the reason for fever. And when you're looking at animal models for stroke, this one study is from Zhao et al. They basically took mice and they purposely occluded their middle cerebral artery, and then they cooled them at different time points, is what you're seeing here. And so they actually cooled them to moderate hypothermia, remember? So this is deeper cooling of 30 degrees, but they only did it for 3 hours. That's also important. So in the first one here, you can see this is what a little mouse MCA territory looks like. It's almost adorable. So this is an infarction here of an MCA occlusion in a mouse that was normothermic, so they did not cool him. This is what the MCA looked like after 1 hour of occlusion on this one. But the difference is this mouse was cooled to 30 degrees, and you can see almost, actually, no, there is no infarction at all in this one. And this one was just a little bit delay of 45 minutes at this one. And there is some mild infarction. And then this one was delayed by 75 minutes. And you can see a full territory infarction, which looks pretty comparable. The point of this is that there seems to be a time dependency here of how, when you initiate it. But keep in mind, they only cooled for 3 hours versus in this study where they went to mild hypothermia, not as deep, but they cooled for 24 hours. They showed a very similar pattern. When these mice had their MCAs occluded for 2 hours. So it's like you had a stroke, your vessel's occluded, then you had a thrombectomy, you've opened, now you've opened, and here we're going to start cooling you at hour 0 here. You get a 60% reduction in infarct volume. Then at 2 hours, 49% and so forth. You basically lose your effect completely by 6 hours. Okay, again, time dependency here. This same thing is shown on the graph form, losing your effect by 6 hours after reperfusion, not at the start of occlusion, but after reperfusion. That's an important discrepancy because that gives you an extra 2 hours. I already said the discrepancy. So what's the discrepancy between those two studies? Well, one was cooling for 3 hours, the other was cooling for 24 hours. Again, going back to this, dying is an active process. We know that there are inflammatory cytokines and caspases that we just mentioned. And in fact, in the Shintani study, they looked specifically at mRNA expression of these specific cytokines, heat shock protein caspases. And if you notice, so first of all, in the purple is penumbra, like this line, for instance, on this one is the penumbra. Red is infarcted tissue. But if you notice that many of these inflammatory cytokines are being released at anywhere between 8 and 24 hours. For instance, if you look at INOS here, which, by the way, it will be decreased by 50-fold in the hypothermic mice. it starts to peak at about 8 hours in the penumbra, right? So, and this is the tissue that we care most about. So if you were to stop cooling down here at 3 hours, you might not have any benefit. And again, if you look at heat shock protein 70, if you're following the penumbra, again, peaking around 8 hours, and you still have it pretty high, you know, up to 16 to 24 hours, also increased 20 times in hypothermic mice. Caspase, same story, peaking at 24 hours, right? So this is where the duration part of that comes into. And this is where the evidence comes that we should be cooling for at least 24 hours. In fact, what I didn't mention about the babies, the hypoxic ischemic encephalopathy neonates, they are cooled for 72 hours, not for 24. I forgot to mention that. This is neuroprotectin. One is a protein that's released to protect the brain following ischemia. When they measured this in the hypothermic pigs, you can see it looks like a 5-fold increase in that. So we know that at least on a molecular level, these things are being released. We're trying to basically translate animal studies to humans right now, which is quite challenging. So key points: speed matters. It looks like the therapeutic window from animal models is somewhere between the 4 and 6 hour range. Depth matters, at least 32 to 34 degrees. I would love to see a study that goes deeper than that, and maybe 28 to 30 degrees. But we don't have that as of this point. And duration matters. It seems 24 hours at least should be your target. So cooling studies in stroke patients, we've talked about cardiac arrest, we've talked about babies. Well, what about stroke? So there have been a few trials. This is probably the most cited one. It's called ICTIS, or intravascular cooling in the treatment of stroke 2. They planned for 1,600 patients. It took very long time. They had a slow recruitment. I feel for them. And it was also, they were slow. It took them 1,000 minutes to achieve target temperature. That was their median. And again, they were slow to initiate, 287 minutes, 4.5 hours. This study was eventually stopped early, didn't show any difference between the two groups. Again, they were slow. You've thrown the rotten meat into the freezer by this point. So, and probably no surprise, because if you look here at this same graph that I showed you before, if you're not getting down to target temperature from here or beyond, there's probably not much to save by that point. A study that came out was published in 2019. Again, impetus to do this talk was very ambitious. 36 sites, planned for 1,400 patients. Same results. They had to stop early. Why? It's difficult to cool patients. It requires a lot of manpower, as we've learned over these years. And of the 1,400 patients that they had planned, they only enrolled 98 patients in 12 sites. And of those ones that were cooled, only 31% actually achieved therapeutic hypothermia, less than 35. So of course, no difference was found in the group. So this was 2 dud studies, right? So that's all depressing. And then I bring you Cisco, which I hope will be the answer to those previous studies. And what did we say the key factor was, or the key factors were? Depth, right? So your speed, your depth, and your duration, right? So Cisco very well could answer at least the first part of it. So Cisco uses a life recovery thermosuit. We are now testing this device to rapidly cool patients to mild hypothermia with acute stroke. Right now, we're a safety and feasibility trial. All we have to do, is cool at this site 15 patients, and 50% of them need to be cooled within an hour. 1 hour, 60 minutes. Now, keep in mind, all the other trials I just showed you were several hours, if you remember. In fact, the quickest one was 2 hours. From cardiac arrest trials using this device, with propofol can get someone's target temperature down to 27 minutes. Now, cardiac arrest has one advantage, or a couple of advantages over stroke patients. The biggest thing is that they're unconscious and their thermoregulatory mechanisms are not as robust as an awake stroke patient, as you guys have seen. The way it works is it uses thin liquid convection. So in this is basically a tank of ice water, and these are pumps that are rapidly circulating at 13 liters per minute, ice cold water directly on the patient's skin. This inflates around the patient, basically creating a pool that is rapidly circulated. There is this cover on top of the patient as well, and water is moving on both sides, on their back and on their front. This is actually a picture of us doing it. You can see some familiar faces here. There's Dr. Eisen, there's Derek, Olivia. You might recognize someone in there too. Talo's here. And so this is one of their pictures of a cool patient. So the goal, again, is safety and feasibility using rapid cooling of the life recovery thermosuit for patients with ischemic stroke. And as you can see here, compared to any of the other mechanisms, it is several orders of magnitude faster. Potentially could get someone's temperature down to target, meaning 33 degrees in half an hour, okay? But has it, so if we could potentially do that, someone's having a stroke, right? Vessels occluded, they get to thrombectomy, maybe we get to them and we can start cooling them at 3 hours. Well, we could be much closer to up here on that curve, or maybe here, but certainly not down here. It is possible with this device that we could actually cool someone fast enough that we could protect 60%, 50%, 30%, 15%, some measurable amount of infarct core. So in order to be included in this trial, you have to be older than 18 years old. You have to have a stroke scale of 6 or more. If they got TPA, it has to be within 3 hours, and we are accepting thrombectomy patients. I'm just going to jump to some of the results. So actually, this is the first time we've shared these results. We've actually enrolled 10 patients into the study, 9 of whom were actually cooled. The average NIH was 17.4, a variety of different types of strokes, both posterior and anterior circulation. And you can see here our time to cooling to purge temperature, which changed, was 40 minutes. But it's either between 40 and 58 minutes. This is actually the time, because initially our purge temperature, I think Bob's on here, I think it was 34 degrees. The point is, this is the bottom line. Our average temperature, our time to target is 58 minutes, which is half the time of the fastest trial to date for cardiac arrest, and several times faster than either stroke trial that was done. In terms of outcomes, we don't have any comparator. We don't have a control group. Remember, this is just safety and feasibility, but we will be comparing these to historical controls when we're at that stage. But in terms of outcomes, follow-up NIHSS 2.6, follow-up MRS is 2. The goal is, if this ever picks up, we can get this approved. We can get through the phase 2, maybe turn this into a large multi-site randomized trial where instead of just looking for feasibility and safety, we can actually look to see, well, is this helping? Can we actually measure an appreciable loss in infarct volume or functional outcomes in patients? But you could see a scenario now, we have thrombectomy, which is now standard of care. You guys take that for granted, the residents in here. But many of us who were training, we didn't have thrombectomy through training, right? And so now the question is, how can you get more people that treatment, right? You can only take someone to thrombectomy if they have viable tissue. You cannot take someone to thrombectomy if their cord penumbra ratio is too high. So they have to have viable penumbra. So potentially we're a large telestroke site now. We have now 20 sites, I believe. Dr. Eisen might be able to correct me, but I think we're at 20 sites now throughout the Louisiana, Mississippi, Gulf Coast region, and hundreds of miles away patients are coming. So someone could have a large vessel ischemic stroke here. They could be given TPA. They could be cooled within 30 minutes to an hour here and then sent to us. And that could potentially increase the chance that they might be viable for a thrombectomy by they get here, or could have all of those other downstream cytokine effects and improve their outcome. This is the hope. This is the vision. I hope you will help us get there. So speed matters, 4 to 6 hours. Depth matters, likely 32 to 34 or less. Duration matters, 24. Thank you. John.
I was wondering about one of those.
Oh, wait, hold on.
Can you all hear me? Oh. Okay. I was wondering about for one of those patients, the NIH stroke scale at discharge was 26, and then they came back at, was it 60 days, and they were down to 8. I don't know if you could get into specifics about that at all. But seems kind of strange that they would be discharged at such a high score there.
I have to look at that. I don't
Okay.
know. I don't know if that's correct or not. I have to.
I think, well, there was one patient who had neurologic worsening due to recurrent strokes while she was in the hospital. She had cardiac arrhythmias and had a thrombus that continued to propagate her stroke. So that was that case. I think it was the second patient.
Oh yeah, she's the one who rapidly warmed.
No, she's the one that we cooled without intubating her, and was a heavy alcoholic, and we had difficulty with getting her sedation corrected.
Yeah. And she had multiple embolic strokes. I remember her
Yeah.
after during that cooling period, and we weren't sure what was going on. She started seizing when we started rewarming her.
Right.
Yeah.
And,
I was not aware that that was her NIH on leaving, but that makes sense because she was pretty neurologically.
She's very sick. Yeah.
And then I was also kind of wondering, you were talking about the inclusion criteria. You know, I guess I think you've told us to try to keep in mind who would be a good candidate for this, but it's never really something I'm thinking about, and it's always seems scary, thinking, oh, should we try to?
So the inclusion criteria right now is pretty broad, but our experience at this point suggests that we should really be only doing this for the bigger strokes, meaning your large vessel occlusions. Our experience also dictates that it's far less stressful and probably safer for the patient to be intubated during this. This is a different animal than cardiac arrest patients who are going to automatically, if they're in coma, automatically going to be intubated. So there's always that decision too. You're dropping their temperature down. There's water going on them. So really, this should be reserved for the sicker stroke patients. We've kind of been screening that way too. If they get a thrombectomy, it doesn't have to be within 8 hours. It just has to fit within the American Stroke Association guidelines, which is based off of Dawn and diffuse criteria, which means up to 24 hours if they have favorable penumbra. But that's a good question. And in fact, the reason why patient 1 isn't even included in here is because he was a lower stroke scale to begin with. I think he was like a 6 or a 7, and he wasn't even a stroke. He was a conversion disorder, and when we started cooling him, well, guess what? He woke right up. It's an anti-conversion disorder device. It's very cold.
Justin.
Oh.
Hey, that's super interesting. Not that this is in the same category of stroke, but something that's become really in. I've read about people doing this in Silicon Valley and kind of super performers. taking daily ice baths for mental clarity. Anyway, there's a lot written about this, and apparently it can be better than antidepressants and, other things. I mean, they're touting a number of benefits of it. Are you aware of any other applications? And that protocol is obviously very different because there's
I am aware of it. I haven't read in depth into the science behind it like I have with, for other indications. But I was actually just joking with Dr. Eisen that once I started talking about therapeutic hypothermia on the phone or in text, now I start getting Facebook ads for exactly those cooling barrels for exactly those indications to reduce stress, anxiety, joint pains, and things like that. But I can't give you an intelligent answer on the science behind those things. But presumably, it's founded in the same, similar principles to its protection in brain injury. Yeah.
So I had a question on MRS. I know that it compares MRS at discharge and 90 days follow-up. Why doesn't it compare with the baseline MRS?
It's comparing, so in order to be included, your MRS, actually, I don't know if that we had an MRS criteria to begin with.
It's all been neurologically normal patients before we start cooling. So they all have a modified Rankin score of 0.
Okay, sounds good.
Any other questions?
I got a quick question. So do you think that part of the reason why infants benefit more from this cooling is because of the lack of or decrease in myelination, less insulation in the brain?
I don't know. The only thing I objectively know is that we are able to cool the infants a lot faster. It's just easier to cool an infant for the reasons stated, that their surface to mass ratio is much more favorable for that. But also babies, then you could ask the question, well, maybe they're just a lot more plastic and they can rebound from neurostressors better than an adult. That could also be part of this. But I don't know.
And is this basically through like a diver's reflex that we're cooling them? It's water directly touching their skin, right? And cooling them.
The ones that the method they use 2 methods. They use the head cooling and whole body, and it's with pads, just like a mini Arctic sun.
But the way that you're doing it is with
the way that we're doing it is with direct. It's like falling into an icy river or a creek, and the water's rushing over you.
I think that's really cool because maybe it is like simulating causing a diver's reflex.
Well, so the reason why I think the life recovery suit is so effective is because of the reaction that I talked about, the Lewis reaction. Because you have direct skin contact with water, you're able to cool the skin temperature very quickly. And in fact, it's somewhere around 5-10 minutes that we've found. You'll see them fighting, and the temperature will stay the same for about 5 or 10 minutes. And then around that 10-minute mark, when the skin temperature presumably is dropping below 10 degrees C, they start to vasodilate. And when they vasodilate, you've now turned their skin into a radiator and make convection much more effective because you have moving water. So it's thin liquid convections. You're actually able to remove heat from the patient quite fast. And by using that reaction against them, because they're vasodilate, and because we know that shivering is greatly diminished below 33.5 degrees, they can't shiver as effectively, especially if you keep them on the lower end of that range, so closer to 32.
Okay. Is there also like I know there's heat shock protein that's neuroprotective, but is there anything like a freezer shock protein or anything like that?
A what?
Like freeze, like if you're as you're cooling a person beyond a certain amount, maybe a protein is actually created, not acting like a chaperone, like with heat shock protein, but some other mechanism. Have you heard of anything like that?
I don't know about a freezer shock protein. I'd have to ask Dr. Bix if he's heard of that.
I'm just curious.
I don't know.
This is Bob Schock here. Can I just comment a little bit on the mechanism there?
Yeah.
So from the early animal studies done with this device and in early human studies, we have seen very little shivering. We think there's two basic mechanisms going on. One is the extreme cold water disables the cold firing receptors on the skin. It's one of the shivering triggers. Also, when you make the skin cold, by chilling the muscles that cause shivering don't like to contract when they're cold, and neither do the muscles which cause vasoconstriction. So all those muscles relax and you don't get a strong shivering signal, and that's when the shivering stops. Vasodilated skin is easier to cool, and we are cooling it the most efficient way possible with cold moving ice water. That's what you get. So that we've been pleased to see the results have been what they are. And just a fine point, the last two cases they did were the only two, I think, so far with the new software and the device. Based on the early cases, we realized we needed to cool a little deeper before we purge the water out of the thermosuit. So now we cool all the way down to 33.5 C before the water's purged out. And that guarantees you get below the shivering level. And then you don't stall out with a slow cool process as we did with a couple of earlier cases. So that just, Dr. Salerian and Dr. Eisen and the team there have done a terrific job working through the protocol, and we've been improving it as we've gone along, and I'm sure we're not done improving it.
Thank you.
Welcome.
Any other questions, concerns, comments?
Dr. Salerian, it's Serene. Dr. Perez's mic is not working, but she's asking if there's any concern for bleeding given the lower temperatures and inability of platelets to fully function at lower temperatures.
There is a theoretical concern that has not really been borne out in any of the post-cardiac arrest trials or in our trial or in prior stroke trials. So theoretically, we know that the coagulation cascade doesn't work as effectively, nor do platelets. And in fact, that's part of the exclusion criteria of this study. Those patients who have any active bleeding or anything like that are excluded.
We have to add though that we had a patient who had early cerebral edema and went for a decompressive hemicranie and actually had the surgical procedure while she was at therapeutic hypothermia and did not have any additional bleeding complications and had no need for blood products or anything like that. The surgeons didn't have any kind of additional coagulation problems while she was in the OR.
Yeah, and I will also add that most of those concerns arise from deep or profound hypothermia under 28 degrees. Certainly under 28, but under 30. We're at 32 here. Okay, well, thank you very much, everybody, for your attention. I hope we get to cool some people soon.
Great job, Dr. Salerian.
All right.
Yes. Thank you, Justin. Thank you, Amy. Thank you, everyone.
Should I stop sharing or you need it? Stop.